So I'm an eye doctor, so what on earth am I doing showing you pictures about swellings around the midface? That's because in ophthalmology we have 9 different areas within one specialty. My father's a GP, he's just retired, he was 74, oldest GP in the country, and to his last day as a general practitioner he couldn't quite work out how there could be 7 different specialties or more within the field of ophthalmology. And what I do is disease around the eye, so I no longer do operations within the eye. And that takes me to areas like infections, injuries, trauma, cancer, and those sorts of problems. And so the talk that I've got to share with you is called really algorithms of eyelid swelling. When we're faced with a patient with eyelid swelling, how on earth do we work out what it could be? Now, in this country, we're very good diagnosticians. The one thing that you will end up being here is you will be a very good diagnostician because you have a lot of clinical material. Whereas when you go to other countries, you'll find that the first knee-jerk response is to do a scan straight away. And the one great thing, amongst many things in the NHS, is you'll see so much pathology. By the time you get to my age and beyond, you will be a very good diagnostician. So what I've tried to do is to put down a series of ideas as to how I diagnose patients with lid swelling, and whether you're a dental student, and in fact one of the main patients I'll show you, I was up half last Sunday, was a dental patient who presented with an eyelid swelling, more on that later. You will see eyelid swellings, you're going to see traumas, you're going to see strange injuries, because injuries don't respect surgical boundaries. So this talk is a little bit off the beaten track for you, but actually you're going to come across this pathology again in future, sooner or later. So here's a whole range of different strange, nasty looking swellings. Some of them look rather dangerous, some of them look a little bit uncomfortable, and some of them just look downright ugly, like this one here, and some of them have light shining through them. And so what I'm going to do is look at a way of breaking these down into age groups and whether they are or are not swollen to try to work out what they are. So this is like a detective game, if you like. So that's the title. It's an algorithmic approach to diagnosing periocular swellings. And my overview is that swellings in the midface don't always relate to an eye condition. So they may occur with eyelid, sinus, and orbital pathologies, and they may occur with dental pathologies too, as I'll show you later. And some things that we see have key distinguishing features, what they call the end-of-the-bed diagnosis, the barn door diagnosis. In other words, you spot it and bang, you've got the diagnosis, like the patient who walks in with a great big swelling up around the eyelid, and you think, that is an ethmoid mucocele. And they sit down and you say, you've got an ethmoid mucocele. How did you know? When you've seen enough, life becomes pattern recognition. It's all about pattern recognition. And that's what you'll get good at as clinicians. And some of them have very distinguishing features. And other pathologies can be very life-threatening. Believe it or not, as a humble eye doctor, I deal with life-threatening disease, not infrequently, particularly when it comes to tumours and so on. And the essential investigations, if there are really any, are tumour markers. We live in an age, I'm a dinosaur now, but you people aren't. You're going to live in an age where you actually will discover tumour markers, and you can run a panel of tumour markers and find out what kind of oncogene is driving that particular tumour, and then you'll know how to interfere with the process of the tumour. So you can look at people like me and say, these guys just cut things up, whereas now we apply BRAF, interfering molecules interfere with genes and oncogenes. And so tumour markers will become very important for you as you go on, CT scans and biopsy. But you know what the most important tool you have in your armamentarium? Anybody have any idea what's the most important tool that you've got, and the most powerful one? Which you bring to work every day. It's your brain, it's pattern recognition. There is no human computer, there is no computer made by a human that has ever got to the point yet that can pattern recognize. When you see somebody's face, even if they're very different to their twin brother or sister, you will instantly recognize a difference. And so your ability to recognize patterns and changes of patterns and asymmetry is exquisitely sensitive. In other words, the best tool that you've got, and I haven't put it up, but I've got a great picture of Bart Simpson with a cross-section through his brain. It's not a very big one, but the point is you don't need a big brain to be very, very good at pattern recognition, which is why you've got to spend your whole life seeing patients and recognizing them. When you've got European Working Time Directive, turn up to work again, see more patients, because it's that pattern recognition that's going to make you an extremely good clinician in the future. So here are the basic algorithms that we're looking at. The childhood swellings I want to just go over, swellings which really are in the eyelid, and then swellings that you may think aren't too serious, except they may be very serious indeed. How do we spot malignancy? And then swellings where you also have orbital signs. In other words, there's a much deeper seated inflammation or lack of function of the orbit, which is typically eye movements and vision. So here's the first question. We've got a child, and there's a periorbital swelling with rapid growth. Is there rapid growth? That's the question. And I said, yes, there's a child with rapid growth, and the rapid growth is within the first 6 months of life. So a child presents to you, and anywhere around the orbit, they develop quite a rapidly growing lesion, which may be periodic. And the test that you can use is ultrasound, exactly the same as the investigation that's used for pregnant ladies. Ultrasound, non-invasive, and will show you very clearly lesions with blood vessels in. So here's a picture of a young child that I saw when I was abroad recently with this large lesion in the upper lid. And because of the pattern recognition, and because we had access to ultrasound, we were able to say to the parents, this will get smaller in time. Small child, problem of course of having an occluded eyelid. Can anybody tell me, if you have a child and the eye is working but you cover it, what happens to the neural connections? Does it develop normally? It doesn't. And what's that called? Amblyopia. And people call it a lazy eye, don't they? They come and they say, I've got a lazy eye, doc. So always ask a patient who's got poor vision, you say, did you have a lazy eye when you were younger? Quite often they will. And if you have a child like this with a large lump in the lid that obscures the vision, that child may develop a lazy eye. So what am I trying to show you here? Well, here's a study we did and published looking at these things called capillary hemangiomas. These are a collection of blood vessels thought to derive from placental cells. Very common, strawberry nevus. You probably all have heard of a strawberry nevus. They can appear anywhere on the body. Something like 2 or 3% of all children have them. And actually, if you look at the volume of these, here's a pink line, up, down, up, down, up, down in the first few years of life. They get better, they get worse, they get better, they get worse. So instantly I'm thinking pattern recognition, I'm thinking capillary hemangioma, but I'm also worried about the fact that the eye is closed and there's a risk of amblyopia. And you can use ultrasounds to look at the flow of blood. All right, so just when you're listening to the fetal heart, has anybody been with their parents or aunts or uncles and listened to fetal ultrasound? Yeah? Hands up, anybody? Weren't you amazed by the sound of the heart? And you can actually see it. And actually, if you put the right gates on the ultrasound, you can then colour flow it and give the area of interest a colour which indicates that it's flowing to or from the probe. And so here you see an arterial waveform like this, okay, this saw-tooth appearance from this child who has this high-flow capillary hemangioma. All right. Now, as it turned out, we decided not to operate on that child because a small child was a big lesion, blood loss may have been very considerable. But these days, the treatment for these is propranolol, it's a beta blocker, which was coincidentally found to be highly effective. Now, does anybody know where this might be? The view is not great.
Jerusalem.
Who says Jerusalem? I heard of Turkey. Anywhere else? Okay, now, so what would this structure here be, do you reckon? The Dome of the Rock. Who's been there? Anybody been there? Yeah? And there's the forecourt of the Dome of the Rock. And I'm showing you this because I spent a fair amount of my time abroad, and if you really want to expand your horizons, and you really want to travel and do something in the scope of your career, then it will only be a success if you try and do it. All right? So and I went abroad for a year about 15, 16 years ago. Everybody told me, you'll never get back into the system, you'll never get a job. And it was the best thing I ever did, and I collected a lot of clinical material, and I learnt a lot. I learnt a lot about pattern recognition and how to diagnose eyelid problems and eye problems. And the reason I show that is the next child comes from Jerusalem. Now here's the same question, childhood periorbital swellings. Is there rapid growth? Yes, there is. But is it really rapid? And I'm talking seriously rapid, getting bigger almost in front of you. Because there is a particular condition that can get bigger so fast that in the space of a weekend it can double in size. And this is a very serious condition called rhabdomyosarcoma. Has anyone heard of this? Anyone heard of a child with rhabdomyosarcoma? It's a really nasty disease to have. It's actually not from muscle, even though the definition suggests it's from muscle. It's from mesenchymal soft tissue. And it turns over so fast that while you're waiting to biopsy the patient, it doubles in size. So here's this poor child who pitched up to the St. John Eye Hospital, which is where I worked in Jerusalem for a year, treating patients from all over the country, chiefly Palestinians as it happened. And there's a child with a rapid onset lid swelling in a 6-year-old, and there's the CT scan showing this large mass. And when you have a child, and pattern recognition, you think, there's a lump, it's getting faster by the minute almost, certainly by the day. You're really thinking Burkitt's lymphoma, or you're thinking rhabdomyosarcoma. And what you really need, what you need to do here, we don't know what it is yet, so what would you want to do as a surgeon? Speak up. It doesn't matter if you're wrong. It's great to be wrong now. You can be wrong as much as you want as a student. What would you do? You'd take a biopsy. Of course you would. You'd take a biopsy. Because then you know how to treat them. You know what kind of chemotherapy to use if it was a rhabdo. Your pattern recognition cells have told you that's what it is, or a Burkitt's lymphoma, possibly. It's not very common in that part of the world. So here you see, this is a Barts. In fact, it came out as one enormous lump. There's an enormous plump coming out of the front of the orbit in this boy who was perfectly all right only 6 weeks previously. And here he is afterwards. This is him a week or so after surgery, risk of amblyopia, but he's 6, so by the time you're 10, the risk of amblyopia is much less. And there you see a young medical student or doctor a few years back looking after him. And there I was abroad. And I would say to you, if there's something you really want to do in your career, go and do it, because if you really are inspired to do it, you'll make a success of it. And that includes travelling to other countries and visiting other units and places. So we're still dealing with childhood periorbital swelling. So what about the question if there isn't rapid growth? So we looked at these two that are rapidly growing, well actually 3, what were they? Number 1? Capillary hemangioma. Number 2? Rhabdo. And what was the other one I mentioned? Burkitt's, named after Sir Dennis Burkitt, I think, was in Africa, wasn't it? In fact, so those are the 3 things. So you're learning a lot already. But here's a question. The patient is a young person but does not have rapid growth. And if they have a lump by the orbit which is not changing in size, then you can relax a bit more and your pattern recognitions are flicking on some other switches and you're thinking, right, common problems, not growing rapidly, this is probably going to be a dermoid. And has anybody heard of a dermoid? Oid, derm, skin, a bit like skin. In other words, during embryological development, during the embryonic fissure lines, pieces of skin have been taken in through the skin, typically around the orbit. It's very complex embryological infolding. And those bits of skin get buried deep under the skin, but they carry on growing. But of course it's like a balloon with the inside turned inside out, so they carry on growing, putting all the oil and sometimes hair into the inside of this dermoid. And it gets bigger and bigger and bigger, and it's full of oil. And you can imagine what would happen if the oil leaked out. It would get very inflamed. So these dermoids grow very slowly, but they do get very inflamed if the children get knocked around in the play area at school. So we tend to remove them at the age of 4 or 5. Here you see a child with a large plum-like lesion right on the orbital rim here. Most of these are quite superficial. So here's a superficial one, and most of these tend to be out in the outer corner, because this is a very complex infolding area here. If you feel very carefully, you're probably aware of a little fissure. If you put your finger on your lateral orbit now, and you can feel the bone slightly strange. Don't feel it too much, because you'll pitch up to an eye clinic to determine there's something wrong with you. A lot of patients like that. But actually, we have symmetrical signs. This is zygomatica fissure, okay, zygomatica frontal fissure. And that's where we have this infolding. And if the skin gets taken in at the same time in the first trimester, people end up with these dermoids. And here you see on a scan, here's another dermoid much, much deeper. Okay, they can be really deep if it happens really early. And look what happens to the bone during development. So this is a lump that's pressing on the bone, and during growth, that bone then is contorted, it's scalloped by the chronic presence of this lesion called a dermoid. So instantly you're thinking no rapid growth, maybe a bit of swelling, probably a dermoid. And you'll discover dermoids elsewhere in the body, but they're quite common around the face. So what about the next question? Still no rapid growth, but now the swelling is right underneath the eyelid here, okay? And the patient can often have lacrimal symptoms, i.e. a watery eye. And this picture of a patient with a watery eye with a large swelling underneath the eyelid indicates that the outflow for tears has become blocked or was never properly canalized open. And as a result, upstream, which is the lacrimal sac, become enlarged, leading to a congenital dacryoceal. Ceal meaning sac, dacryo meaning lacrimal. Okay? It's one of these fancy words that takes a bit from Latin and a bit from Greek, and it's called a macaronic word. You stick a word together from 2 different languages, it's called macaronic. Did you know that? There's lots of those in medicine, and you look out for them. It's a dacryoceal. And here you see a picture of a child in whom the drainage down the bottom here, you can just see at the bottom, has become, if you like, obliterated, or has never canalized through. Now you're probably aware that young children do tend to get a watery eye. Are you aware of that? And they tend to grow out of it. And that's because the drainage channels in the eyelids are never open before term. So in other words, if a child was born very early, they're almost certain to have a watery eye. But then the drainage channels naturally open up. But a proportion of them won't do. And in those that don't, they can develop this large swelling in the inner canthus. Okay, the canthus means the corner of the eye. On the other hand, and this is a bit more serious, same question, no rapid growth, but now the swelling is not so much just under the lid here, but you can appreciate that this is more in the midline. And this is very rare indeed, because midline lesions, until proven otherwise, are a meningioceal. Okay, now what do you think a meningioceal is? got the word. Most of medicine is in the word, which is quite fun. What's a meningoseal, do you think?
Swelling of the meninges.
Okay, you've got meninges, right? Meninges are the covering of the brain, and a seal is a sac, so it's like a little sac of meninges, and they've actually got squashed out of the cranial space because there's space for it to fall into. In other words, this patient here has a developmental abnormality in the base of the skull, and therefore the meninges, plus or minus brain material, can then spread into that space. So it could be called meningoencephalocele if there's meninges and brain. If there's just meninges, it's called a meningoseal. Now, why wouldn't you biopsy that? And there's no points for getting this one right, but why wouldn't you biopsy that?
Meningitis.
Yeah, exactly. And if you were to look at the patient very carefully, what might you see? Yeah, you get transmission of arterial waveform, okay? In other words, the CSF would be transmitting that pulsatility. So always look very carefully and palpate. I'm sure you learn in medicine, you look and you listen and you palpate. That's really important. So were you to feel this, you might well feel some pulsatility. So you've got to know when not to biopsy. Now these are as rare as hen's teeth. And probably the only thing you'll remember from today is this. And they are seriously rare, all right? But midline lesions, think of those. So I'm going to look at some other much more localized swellings, which are much, much more common, and you will see these in your practice. So I'm going to ask this question. How can you tell, why would you be suspicious of malignancy? We live in an age of global warming, of increased radiation. We need to know how to spot malignancy very early. It's very common. You know, a lot of people now are going to have their first basal cell carcinoma in their 30s. Now, when I was trained at your stage, the teaching was people are in their 70s by the time they have a skin cancer. I've treated patients as young as 20 or 25, and it's said that you only have to have one bad episode of sunburn and you've doubled your lifelong risk of skin cancer. So we have to know about these risk factors, and we have to know about how to spot it. So here are some clues. Any lump on the lid that's becoming large rapidly, or ulcerated, or is bleeding or painful, or is associated with loss of sensation, is basically malignant until proven otherwise. Now, why do you think loss of sensation would suggest malignancy? Why would that be so? Any ideas? Let's say you've got a tumor and it's getting bigger, and it finds a nerve, and it gets access to the nerve and carries on going. What will it do to the nerve? It will reduce its function, and therefore a patient will report lack of sensation. That's particularly common with some of the tumours that we deal with. So we always feel around the eyelid, we feel for loss of sensation, paresthesia or loss of sensation, malignancy until proven otherwise. And these patients must have a biopsy. Right? There's a big debate in my world as to whether all patients should have a lid lump biopsied. And there are some very typical papillomas and warts that don't. But quite often we find that when we do biopsy, we actually identify a malignancy and not a wart as we suspected. Now here's a really key take-home message. I know that you're not eye surgeons, I know that you're not going to be eye surgeons, but you are going to see patients whom, if you're smart enough, you will refer in a timely way to somebody who does know what's going on. So here are two particular areas we're going to talk about later. Swellings above at the medial canthal tendon, that's a swelling up here, okay? Swellings above the medial canthal tendon are likely to be malignancy. I'll show you some examples. And patients who have chronic ongoing redness of one eyelid. Anything that's asymmetrical should ring an alarm bell with you. Asymmetry is bad news quite often. So, here's the question. Swelling is located to the eyelid. Is it a surface lesion or is it deep? If it's a surface lesion, are there any of the features of malignancy that we've just looked at? Well, the answer is no, we don't think there are. Fine, so what could they be? And there's a whole raft of different pathologies that are largely epithelial that you'll come across. There's a papilloma, for example, a xanthelasma. Can you see these yellow fatty deposits in the eyelids here? It's not really related to eating too much fat, it's more about genetically how we metabolize our fats. All right, so that's the xanthelasma. Here you see a papilloma. That's, if you like, a common gonial wart, sort of papilloma virus of the face. Can cause these extensive papillomas that can block off the tear ducts, for example, and you can get numerous other lesions around the face. And all this is pattern recognition. So if I have to see a patient like this, I'm not instantly thinking this patient needs a biopsy. Number one, it's bilateral, left and right, so it's less likely to be malignant. And number two, the patient says, look doc, had this for 15 years, finally conceived. So you know it's probably not malignant. So chronicity also implies lack of malignancy. But when in doubt, of course, do take the biopsy. So, we have the surface lesion, and if we think, on the other hand, there are features of malignancy, so the answer is yes, there are, the next question we're asking ourselves is there really rapid growth? Well, if there isn't really rapid growth, we're dealing with the common malignancies that you've all read about in the newspapers and you know very well. These do not grow very rapidly. And we're dealing with a basal cell carcinoma, squamous cell carcinoma, or sebaceous carcinoma, or melanoma. All right? These are the typical these are the main BCC, SCC, and melanoma. These are the lesions that you're going to see quite a lot of, no matter what sphere of medicine you're in. And what I train our fellows always to do is to evert the lid. So here's a patient who had come with lid swelling, and when we evert the lid, we see a squamous cell carcinoma of the conjunctiva under the lid. So always look very carefully. Whatever organ you're dealing with, turn it over inside out, have a careful look, because quite often the pathology is tucked away underneath the lid like that. All right, so always evert the lid. On the other hand, if the lesion truly is growing very rapidly, and I mean over a matter of days to weeks, then really there are two key lesions that would fit the bill here. In other words, I have an epithelial lesion on the surface of the lids, growing very rapidly. The two lesions I think of are a keratoacanthoma, which is probably virally based, and it results in a rapid, explosive, almost volcanic kind of eruption from the skin, called a keratoacanthoma. And the other one is a Merkel cell tumor. Whether it truly is from the Merkel cell or not is still under some debate. But a Merkel cell is related to the sensory skin cells under the skin. And these are also called the red devil, because they are red, difficult to treat, and nobody's yet certain as to the optimum treatment, although generally it's wide excision and radiotherapy. And we're just looking at the moment at Moorfields at one of the world's largest studies on these to see what the prognosis is with the red devil. This keratoacanthoma, on the other hand, about 1 in 10 of them is actually a squamous cell carcinoma, but masquerading, if you like, as a keratoacanthoma. And so when we take this away, we always take the base, because the base of any lesion, rather than the crusty top, that's where the true pathology will be. So if you just take a biopsy at the edge of this, the pathologist will say, well, thanks, lots of keratin, lots of sloughing epithelial keratin, and that doesn't give you the diagnosis. So always take the base of any ulcerated lesion. I'm sure that's probably true in oral medicine, dental medicine, whatever. Take the base, because that's where the original pathology is. Okay, so now here's on to, this is a hobby horse of mine, really. Beware indolent lesions. In other words, patients don't arrive in your clinic with a label over their forehead telling you how urgent they are and what you need to do about it. They just come along, they say, Doc, I've got this lid swelling, I've got some gum swelling, I've got a bit of a toothache. And then you're having to employ an enormous number of algorithms that you're going to learn, that you're learning already and you learn on the job, to rapidly narrow it down to the few that you think it's going to be, and then you choose your investigations. That's how medicine works, okay? Otherwise, you're going to have to apply massive differential diagnosis lists to every single patient you see. So look at this patient. He was referred by his GP with a lid cyst, quote unquote, and it's not in any way a reflection on GPs. They have to deal with a lot of complicated pathology. That this patient was thought to have a lid cyst, but the problem is that it extended from the lower lid up into the upper lid. And the message here is that swelling's above the medial canthal tendon. Here's the medial canthal tendon. That's what connects, by the way, your inner eyelids to your skull. That's the tendon which stops the medial eyelids falling off. Any swelling that presents like that is a cancer until proven otherwise. And that might be cancer of the lacrimal sac, or it might be lymphoma. Now the other real killer, and this really is a killer, is the so-called unilateral blepharitis. It doesn't so much present with a swelling, but here's a patient who presented with unilateral, chronic red eyelid and was given drops and creams for months and months and months and went through all sorts of clinics, and it turned out she had this very unusual disease called sebaceous cell carcinoma. Carcinoma meaning cancer from a gland, and we've got glands in our eyelids because they produce oils. Sebaceous cells, sebaceous glands. And this is a real killer because these patients are treated with eye drops for maybe months at a time before the penny drops. And somebody whose pattern recognition is better says, that is sebaceous cell carcinoma until proven otherwise. And it may look rather indolent, but the treatment for that patient is to remove everything. That's called an exenteration. That's what I was doing an hour ago, just down the road. We're removing absolutely everything to attempt to minimise the potential spread of these tumours. So even eye doctors with red eyelids deal with quite dangerous disease. So unilateral disease is always worrisome. Take a Bart, see if in doubt. So here's this is another patient. So this is the similar one. This is the man I showed you before, swelling above the medial canthal tendon. And I remember looking through the GP referral letters in the clinic at St George's, and I was reviewing the letters, and I picked up this one that said, please see this man with a lid cyst. It's been there, rapidly growing, and it's extending upwards. Please see him routinely. So I put him on the front of the pile, got him in the next week. And here he is, and he has this big, large mass in the medial orbit here, as you can see, and that was biopsied, and that identified a transitional cell tumour of the sac. You don't need to worry about the exact diagnosis. It was a tumour of the lacrimal sac, and he had that removed, and it was incomplete, and so he required an exenteration, removal of the entire eye and eyelids, just leaving a hole there, effectively, just having had a so-called lid cyst. So apparently benign disease can be very, very dangerous. And here's that patient with a unilateral blepharitis, and she had had lid biopsies, and eventually she was found to have invasive sebaceous cell carcinoma of the eyelids. And quite frankly, there's not much to see from where I'm standing, there's even less to see where you're sitting. But any patient who has unilateral signs that don't get better with standard treatment, a penny should drop in your mind. Does this patient have a malignancy? And that goes for any part of medicine. You know, medicine's very similar. Pattern recognition, chronicity, patients not getting better. And the problem is that when you read the notes, the last person has said, whatever they've said, give some drops, maybe a little bit better, see in 6 months. And there you are, busy clinic. Well, maybe she's not worse. Give some more drops, see you in 6 months. And so the error is repeated. And so you should always say, that last person should have been wrong. It might even have been the great professor or anybody. Never be afraid to say, could the diagnosis be right? Because several times in your career, you will be right if you ask the question. Just like this patient who'd been through numerous other consultant clinics. And there's her exenteration. Everything was removed. Absolutely everything. The nose would be in the middle, if you like. Absolutely everything was removed to remove everything back to the bone. And here she is healing very well. And that was 7 years ago, and she's still doing fine. And actually, she sells food in the Smithfield market. And every time she comes in, she brings me a little pot of honey. And a lot of these patients are very unhappy with the pain and the ache. And they come in, and even they've lost an eye, they are people again, and they're happy. And they're living a life, and they're not in pain. And they don't mind the fact they've only got the one eye. Somebody, somewhere got the diagnosis from pattern recognition and treated them early enough to save their life. So, what then of, these are lesions we've seen that are on the front of the skin, if you like. What about much deeper lesions? What about lumps that appear to be deeper? Are they all cancerous? Well, no, of course they're not. Here's a very common pathology. Here's the question. It's subcutaneous with some inflammation. And common things are common. That's a good saying in medicine. Common things are common, so you see them again and again. And here's a patient with a large lid cyst, which transilluminates because the lid cyst is full of oil produced by the very same sebum glands that, if they become cancerous, gives you what the last patient had, sebaceous carcinoma. But in this case, the oils build up in the lid. They no longer express themselves onto the front of the eye, and the result is the patient develops a large lump. Has anybody actually ever had one of these? I'm sure somebody in the room probably has. Or do you know anybody who's had one of these, a chalazion in the eyelid? They're very, very common. So I'm afraid they're very, very common. And they tend to get better by themselves. And then patients get a rash and they get 3 or 4 at once. Very miserable. Here's another one in the upper lid. And here's one in the lower lid. And they can be incised from the back of the lid, or you can inject steroids and they tend to get better by themselves. So, next question, next pattern recognition. Same scenario, it's deep. But this time, instead of a small localized swelling, we have a diffuse eyelid swelling with a diffuse edema. And those are systemic disease. So here you have a whole lid that's swollen. All right. Now, as you know, swelling is not a diagnosis. It just tells you there's edema there. It tells you there's edema because there's been some inflammatory event. Here's a patient with an inflamed upper lid. When you lift the lid, the eye underneath basically looks normal and it's moving. So you can think, phew, the orbit isn't infected or involved, it's just the eyelid. And that's called preseptal cellulitis. Now, children are very prone to this. They're a bit prone to this. You've all seen children with snotty noses, and you might see them sometimes with swelling in the eyelids when they really have a bad cold. The ethmoid sinuses become blocked up. So that's a preseptal cellulitis. This patient, on the other hand, has a lid abscess, rather like the dental patient that I haven't forgotten about, that I'm going to come on to in a minute. I put some dental patient in. But this patient had a lid abscess in the upper lid, which required drainage. And this patient was really weird. I put this in because it was so unusual. Just occasionally you have a complete googly come at you that you've never seen before, and it takes a long time to diagnose them. And you have to take a biopsy, and you get other people involved, and you don't know what's going on. You talk to your back surgeon, you talk to the ENT, you talk to your eye doctor, talk to dermatologists, because sometimes two minds are a lot better than one. So this sort of patient had a really unusual condition called xanthogranuloma, which I won't go into now. On the other hand, you had some very unusual skin conditions. So same scenario, a deep lid thickening, lots of edema, but not responding to treatment. And as a simple eye doctor, I often rely on the advice of skin doctors, because they are experts at dealing with parasitology, for example. I mean, London's a very cosmopolitan place. People come through all the time with all sorts of unusual parasites, refractory diseases. So it's a great place to work in that regard. This patient for 4 months looked like this. She was in quite a lot of pain. Eventually, she was found to have this unusual condition called discoid lupus erythematosus. All right. So when you have an unusual condition, talk to the dermatologists, because they're actually very good at helping you understand why skin might be inflamed. On the other hand, as you saw in that child with that swelling over the lacrimal area, if the tears, which are not flowing, become stagnant and infected, then here's a patient with a deep subcutaneous mass, so subcutaneous, diffuse swelling centered over the lacrimal sac, and this is called dacrocystitis. This is very common in certain parts of the world where it's dusty, where the environment is potentially polluted. When I was in Israel, I saw people in their teens and 20s have infections. It's a bit like a tooth abscess, but it's an abscess in the lateral sac. But in a more polluted environment, patients tend to develop this much earlier, in their 20s and 30s. But this is something we tend to see here in the 40s and 50s. So that is my equivalent of your tooth abscess, in effect. And where there is pus, what do you do with pus? What do you do with the devil? You let it out, you drain it. Okay, that's what you do. You've got to let it out, because the inflammation will get better much quicker. Do you think if you had a big abscess, that filling the patient with antibiotics is going to make a big difference? Probably not. Whereas if you let it out, they get better literally within hours quite often. I can't show you all of it, but I've got some great pictures I'd love to show on another occasion. So here's a patient. This is a white van driver. There's a white van there. And basically he had exactly what I've just shown you. Somebody's turning away. Sorry. I couldn't bring a patient, so I thought I'd keep you awake some other way. I've got to watch out for lid lag at the back. That's my job as an eye and lid doctor. Okay, so here's a patient with a large swelling in the lower lid, and this was drained because the lacrimal system was blocked into the nose. And so where there's a lot of pus, what do?
Right.
We let it out, okay, we drain it, and he drained a lot. Now, his whole lacrimal system is blocked, and the received wisdom is, right, let it all settle, then do a lacrimal operation later. Whereas most of us now feel, I certainly do, actually, if you do the operation at the same time and get the whole drainage sorted out, they're sorted, particularly since he's a white van man and he wasn't going to come back to clinic. So I operated on him, and there you are. That's the same operation. We drained the sac. Look how much less red it is. Done the DCR incision and left the silicone sticking out of his nose. Now, if you're ever overtaken by a white van man with a piece of elastic sticking out of his nose, can you refer him back to me? Because he never turned up to clinic again. You should have had to take it out. Okay. So we're coming on to a few other things. Orbital fat prolapse. We live in a very aesthetically aware world these days, and now GPs are referring all sorts of patients who have basically a bit of orbital fat into the lower and the upper lids. And it's a real nuisance because you spend 20 minutes telling them it's normal, but only being 99% sure it's normal, and there's nothing wrong with them, and they need to go away again because the NHS can't afford really to be doing aesthetic surgery on all these patients, and I had several this morning. So here's a patient, but these are quite bad. Look at that lid fullness. That's orbital fat prolapse. Bilateral, so instantly you're a bit less worried, both sides, been there for a long time, and he's got that really tired look. And here's a philosophical question. At what point do you offer this patient surgery on the NHS? Is it normal or is it abnormal? That's a difficult question, and there's a lot less money around. When you're my age, you will be regulated in terms of what you operate on. Your managers will come to you and say, right, Isabel, you've operated on this fat prolapse and this cancer, but actually you shouldn't have done those other operations because you don't have the money for it. And it's already starting. That's called commission. Okay. So I'm not sure what to do with this man, whether to offer him surgery or not. Difficult one. Here's another one with the same fat, but now slipping under the lid, under the conjunctiva. You can probably see that at the back. And there's the CT scan. So is fat black or white on a CT scan? It's black, isn't it? And what are the units that we use when we look at a CT scan? Anybody know that you get big points with this? You get big bloody points. Do you know what the units are for a CT scan? because you'll be using this in dental work too, of course. Hounsfield units, right? It says Hounsfield units. So if you really want to know whether this is fat or whether it's just a bit of air, you can actually be really smart at it, and you can say to your radiologist, excuse me, what are the Hounsfield units for that area? Because that's different compared to whether it's fat, water, or air. All right? Are you all still with me now? Want to sleep yet? Good. Okay, we're more than halfway.
David, can I ask you a question? Who was Hounsfield?
Oh, so Dennis Hounsfield, Scottish physician of the 50s?
No. He won the Nobel Prize. He was an engineer and he worked for EMI. And he converted routine X-rays into CT scan. So he was basically an engineer who worked for EMI.
Yeah.
What does EMI stand for? We used to buy pop music, something music industry.
Something electrical music industry.
English music industries maybe, something like that.
Yeah.
So that's who he was. And that was in the 70s.
I suppose so. In our recent history, I was born in shorts then, but people forget about that. But you can tell a lot from a CT scan. The great thing is it's invented here. Fantastic, all right? A bit like television and all the rest of it. So, what about other? So coming on, you're still awake. I'm impressed, really. So here we have another patient. So he has a lump deep in the skin, and these are really tricky. I had one this morning. Episodic edema. It comes, it goes. It comes, it goes. They wake up. There's a bad hay fever day. It gets worse. It gets better. What's that sort of picture? Of bilateral, so probably not malignant, swelling comes and goes. Allergy, there's a lot of allergy. Everybody's got a peanut allergy. I sent my child on a bushwhacker camping holiday yesterday. He had God, it's today's birthday. No, it's tomorrow. It's tomorrow, but mine's the next day, by the way. So it's tomorrow. And we sent him with this huge cake, but the only thing it had to be was nut-free, because if some child on a bus has a nut allergy, in other words, allergies are a real problem. If you get on an aeroplane with a bag of nuts, they'll just throw you out the window. I mean, quite literally, you'll be taken off by the police if you open a bag of nuts on an aeroplane, and I kid you not. So allergies are a real problem, and we have allergy consultants now that work in Barts. There are some very good colleagues, and they do these skin prick tests, okay? And they can look at 18 to 20 plus different allergens, and can actually find out why your patient is having episodic laryngeal edema, eyelid edema, for example, like this patient. Here you're going to have an interesting guy. This chap here, he has an allergic IgE response. He develops this lid swelling literally overnight, bang, like a bee sting. You just wave the steroid box in front of him and it gets better like that. Quite literally, this was like 6 hours after taking oral steroids, and it came and it went and it came and it went, and he's got some sort of an IgE allergic response. I'm no expert, but I know that this IgE means allergy, and I've got 2 or 3 patients like this, another one this morning. And here's another patient. I don't know what's going on with her, I'm afraid. She doesn't fit my diagnostic my algorithmic process. I don't know what's going on with her, but what I do know, it's episodic, it's bilateral, it's inflammatory, therefore it's not malignant, therefore it's probably allergic of some form. And a lot of these patients, while you're trying to investigate them, they get better and they don't come back to clinic, so you don't always know what the final diagnosis was. Here's another patient, still subcutaneous, a rubbery lesion in the lid. And rubbery tends to be synonymous with a neurofibroma, which is a benign overgrowth of the nerves. We have nerves throughout the skin. And have you ever heard of the elephant man? Have you heard of the elephant man? It's awful. The Victorian days, and the way people could feed themselves to show off some grotesque anatomical deformity they had. What a sad time it was. The elephant man was a man with multiple neurofibromata everywhere. So what we're seeing here is one tiny part of what the elephant man would have been. NF, and it can be horrible and disfiguring. I mean, there are still patients around like that. Can you imagine a society where people could only feed themselves by showing themselves off like that? Okay, now when we deal with deeper lesions which are yellow or orange in my mind tips the switch for thinking histiocytic. Histiocytic is a certain kind of inflammation, and it gets confusing, but there are certain kind of cells called monocytes that you know in macrophages, and they start gobbling up the fat, which they shouldn't do. And they get loaded with fat, I mean real whoppers these cells are, and they get fat laden and it's orange, and they get deposited here. Here's a patient with this thing called a xantho, meaning yellow, granuloma, kind of inflammation, full of fat cells that just don't know what to do with themselves apart from eat fat. And nobody quite knows why this happens, whether it truly is a form of monoclonal malignancy or not. That's called xanthogranuloma. Once again, the name is actually, the answer's in the name. Here's another patient who has a yellow appearance, and that can be indicative of amyloid. Has anyone heard of amyloid? What is amyloid? Any ideas what amyloid is? Immunoglobulins. Lots of immunoglobulins just laid down these fibrillary patterns. Amyloid. So you don't need to really know a lot about medicine, but once you start to recognize these patterns, And I bet you if I gave this lecture 2 or 3 times, I could clear up these slides and you'd get the diagnoses faster than any ophthalmic people, just because you've learned the patterns of the way to think, colour, depth, chronicity, etc. Here's another nasty example of granuloma, which you see here, sort of a fullness in each lid. So we're coming on now, am I right, about 80% through, am I okay with time?
Yeah, fine, yes.
When people start nodding off, I'll get the hint really. So we've still got a patient with a lid disease, but now they're going to help us because they've got a systemic disease. And a lot of what we see, patients have systemic disease. And you've heard of a philosopher called Occam. Have you heard of Occam? William of Occam? Someone's nodding. Anybody know what William Occam kind of did or thought? Well, it basically boils down to that, doesn't it? That's right. In other words, don't suggest 2 pathologies for a problem when one will do. In other words, if one pathology will just explain why the patient has chest problems and a skin plaque, why suggest 2 pathologies? That was, in a nutshell, what William of Occam described. Okay, so it's called Occam's razor. You've heard of that, Occam's razor? So, in other words, if you've got a patient with systemic disease and an eyelid problem, or a gum problem for that matter, try to piece the 2 together. And quite often patients come and they say, oh, I've had this skin rash, but no GP or dermatologist has ever told me what it is. And I've also got this eye problem or this gum problem. And if you can put the 2 together, you can give the patient a diagnosis. So here's a patient I saw this morning with top sarcoid plaques. He's got respiratory problems under the Brompton. He gets these violaceous thickenings of the eyelids. That's a sarcoid plaque. Here's another chap beneath in the middle. He's also got sarcoidosis. He's got chronic lacrimal gland swelling. It's bilateral, so that means what? It's probably not going to be great. It's been there for a long time, which means it also probably isn't cancer. And we know that he's got sarcoidosis. It's more common in which ethnic group? It tends to be more common in Afro-Caribbean. I don't know why, but it's more common in Afro-Caribbean patients. And here's our patient down here. This is a lady who finally was given a diagnosis of lupus. Okay, lupus. Does anybody know what lupus means in Italian? It means wolf. Okay, it's got something. I want you to go and read this up later tonight. Why lupus is named after a wolf? I'm not too sure. Okay, someone will do that, right? If on the other hand the patient says, the funny thing is I've got this lid swelling, and it only comes when I'm straining on the loo, and I feel like my eye's about to burst, or my eyelid skin gets very full, then you should think of, what should you think of? What gets bigger when you strain? A blood vessel, okay? A blood vessel. It's like a varicose vein. If you've got a varicose vein and you sit on an aeroplane for 8 hours, what happens to your legs? They're not very nice, is it? Okay, there's venous stasis. So here's a patient. Every time I just leant her down, I said, put your head down, my dear. And I said, I'm going to take a photograph. The moment you get back up, she comes up, snap, and there you see her with this lump that she describes. But most of the time it's not visible unless she puts her head down when she strains. So that's going to be a varix. There's another one, that's a really bad one, by the way. They often get them in the mouth too, by the way. Do you know if you have a varix here, it's hemifacial, so look in the mouth as well. That's relevant to you as well. So, I'm going to ask another question now. We're coming on to the last part. Again, we've got a patient with lid fullness, but now it's a whole lot more serious, because not only is the lid involved, but you've got other problems. The eyeball isn't moving properly, and the patient may not see very clearly. In other words, they've got inflammation, and they've got orbital signs. So they've got orbital signs, they can't move the eye, they can't see, they've got inflammation. And now you're really looking at some serious pathology here, potentially. They're unwell, they've had an ear, nose and throat surgery, they've had a dental extraction the day before, for example. And until proven otherwise, what these patients got? Rubor, dolor, calor, tremor. Who said, whose 4 words are those? Rubor, calor, dolor. We no longer repeat the oath when we become doctors, but who was he? Yeah, all right. And he described rubor, which is red, calor, heat, dolor, pain, tremor, okay, swelling, tumor or the swelling, and that implies inflammation, implies infection, and it's around the eye. So here's a patient who said, I've had some blocked sinuses, double vision, it's achy, my lid is swollen. Until proven that otherwise, that patient's got an infection, because if you don't treat him, they can go blind quite quickly. So you put them on antibiotics and then do the scan. So we treat them very, very early. Here's a patient who almost stopped me going on holiday 8 days ago. I got to Gatwick, the last called patient, because I was just about to head off. I said, I've got this patient who's had a tooth extraction about a week and a half ago. And he'd come from another hospital, none of our trusts, where he'd had the sinuses drained, and he had a CT scan done the following day after the sinuses, and I spoke to the colleague of mine. He said, the orbit's settling, he had some lid swelling, but now it's settling, we've drained all the pus, there's nothing to worry about. And that was on Saturday, so I said, fine. brought him up on Sunday. I had a bit of a hunch, didn't like this, because nobody really checked his vision very well. His vision was down so bad he couldn't see any colour. His pupil wasn't reacting. Okay, he had a fixed dilated pupil, and he had a tense orbit, and there he is here. Okay, and when you lift up his eyelid, what's white and mucky? What tends to be white and mucky? Pus. It's already starting to come out from his orbit through the conjunctiva. So when there's pus, what do? You drain it, exactly. So that's exactly what we did. So it was a Sunday afternoon, and I had a flight to catch, and there were about 3 patients in front of me. And I couldn't persuade them I should do the case first, because why couldn't I do this infected case before a corneal graft? We always do infections at the end of the lists, obviously, because you don't want the risks of getting infections with previous patients on the list unless it needs to be done within an hour or two. So here's a video. Hope you don't mind. We'll try and watch this.
Yeah, you can start now.
Okay, yes, exactly.
You keep recording, thank you very much. Okay, Ramsey will keep that clean.
Didn't know I was going to
Keep recording.
Look at it coming out under the conjunctiva. It's all spilling out here.
Very good.
Well, a bit shocking, isn't it?
Just
Sorry,
something-
I can't show you a patient. I can show you a real patient.
Yes, where is the zone are you showing?
That's good, you're doing very well, thank you.
That's called laudable pus.
That's it.
Like it.
It's the joy that a surgeon feels when they've
Fine, very gentle
got pus out.
counter pressure. That's fine.
It's
Nothing better in life.
It's worth missing an aeroplane for. I didn't quite miss an aeroplane. I didn't quite, but it's almost worth missing an aeroplane for. So there was a really important message to me. I've been doing this not a long time, not as long as Professor Hutchison. I'm relatively a beginner. But the one thing I have learnt is, and it's something my grandfather taught me, who was a big surgeon in his days. He said, put your hand on your patient every day, by which he meant these days you can't because we don't have inpatient wards for half of what we do, but see the patient, actually connect with the patient to figure out what's going on, because this patient has been seen within the previous 48 hours by a lot of other doctors who said, the eye's getting better, the eye's getting better. And I thought the last thing I need to do is to go in on a Sunday afternoon and wait for endless other operations to be done, miss a flight to see a patient that may or may not need surgery. I was so glad that I did, because there's a major mortality from having pus in the orbit, because what's above the orbit? The brain, okay, and the orbit has holes in the back, okay, called foramina. In other words, you can get embolic events going further back. There is a 5% risk of mortality from that sort of infection, so we let it out as fast as we can. And here we are. Now, here's something, I must have left a foreign body in there. What do you think I've left in there? A piece of rubber sticking out. It's a drain. Why would I bother doing that?
For the drainage of the breast.
And let it carry on coming out. And then after a day or so the next day we removed that. I didn't bother stitching it back together because it heals. And he was so happy. What did he do? He took his own discharge. Because that's 2 people you need to refer back to me if you see. A chap with a slightly droopy eyelid and another chap with a bit of elastic hanging out of his nose. They took their own discharge the next day. Okay. And here's the scan. And I've taken any identifying factors off here. But if you look here, it says there remains, this is third line, this is from the day before, there remains no evidence of the intraorbital abscess or collections. So there's a message there. Boy, is there a message there. It would be easier for me to sit at home and say, well, the fellow says he's getting a bit better. We'll see him in a couple of days' time. I mean, this was already starting to discharge, and he was losing vision. He had an optic neuropathy, means losing vision. And there you see during the surgery, just identifying the pus, and it came out there. So that's pretty serious, and that was from presumed from a dental infection. He had a tooth problem a week or so earlier. So we're going to just look at 1 or 2 other things before I finish. Thyroid problems are very common. Thyroid glands, particularly in women in their 3rd, 4th decades, if you have an abnormal thyroid gland, it can affect the eyes. It can be a devastating condition, and it can present with eyes getting bulgy and eyelids going up. So when I see a patient who has some lid fullness, bilateral, it can be inflamed, the eyelids yanked up here, that's very unusual, by the way. All of us might have lower lids, lower than our corneas, but if ever you see someone with an upper lid above the cornea, that is always pathological, always. There is no natural condition in which you would have an eyelid higher than it should be, unless you're frightened or you have thyroid eye disease or some other problem. And that's how we transmit fear to people, by raising our eyelids in fear. Adrenaline goes around, you raise your eyelids, you're automatically on alert. Okay, so it's not. So these patients walk around looking like this, feeling frightened and frightening other people. Thyroid eye disease, it results in swelling of muscles, pulling up, and that's very common. And if you see somebody on a train or a tube and you can see they've got really quite protrudent eyes, likelihood is they've had some thyroid problems actually. Some of them are very bad. She was very bad. Some of them are not so bad. There are other conditions. I've got a few more to just talk about. Same problem, inflammation, very, very rapid onset. And this is called myositis. If a muscle gets inflamed, patients say, I was fine the night before. The night before, I had a little bit of a fluid type symptom. I woke up in the morning, my eyelid was closed, and when I tried to look to the side, I got double vision. And that is classic for myositis, means inflammation of a muscle. So I don't need to spend a long time looking at that patient because the history has told me the diagnosis history. Most of it's in the history. It's 95% in the history. If, on the other hand, it's very, very slow, if the inflammation is very slow, then they may have an unusual inflammation of the lacrimal gland. Can we all point to where our lacrimal glands are? Can you always point to where your lacrimal gland is? Maybe the last time in your career you ever actually point to your lacrimal gland. It gets right under the rim of the bone here. And these can get inflamed in sarcoidosis, which you've already seen, and a number of other conditions, but tends to be quite slow. So I'm going to miss out some of those because you have absorbed a lot of information. Now, pattern recognition with pulsatility. What does pulsatility mean? I touched on it at the very beginning. What does pulsatility imply? Vessels, exactly. So if a patient who comes along like this with a proptosed eye, the eye is bulging forwards, and they have beefy blood vessels that are, and it's pulsatile, you put your finger gently on the upper lid and it's pulsatile, what does that imply? Some abnormal connection behind the eyeball through the blood vessels. In other words, there may be something called a fistula between the arteries and the veins in the orbit or behind the orbit, and that's called a cavernous sinus fistula. So pulsatility implies abnormal blood vessel and connections. So we're almost there. You really are. You're doing very well. We've come on to, we looked at dermoid very briefly in children, and the dermoids can also get quite inflamed and they may be very chronic. So dermoids, as you now know, are all against the zygomatica suture. And what do they come from? Abnormal skin invagination. You're doing far better than my last audience. There's a dermoid, and they contain hair, and they contain oil. Here's one I took out, and the more I turned it round, and I shone a light through it, and however I turned it round, the contents, the proteinaceous material, much lighter, was floating on the oil. That was extraordinary. You can see the top is dark, and as I rotate it around, the dark bit stays at the top. I'm rather proud of those pictures, really. That's a dermoid, to show you how much oil is produced by our skin, and that's exactly what it is. Okay, I'm not going to go through that one. What I want to have a passing word really with lymphoma. Lymphoma is very common. It seems to be becoming more common. Cancers never come with a label on them. Lymphomas really don't come with a label on them because they can be slow, fast, inflamed, not inflamed. But if you have a patient who basically has a gradual, painless swelling in the eyelid, the message is two things actually, because I've been caught up. Look up the nose, because the eyes and the sinuses and the nose are connected. And if you look up the nose in a patient with a large swelling on the eyelid, you may well find that this patient has tumour in the nose as well, and that's lymphoma. So don't get locked into your specialty. If you're dentists, think outside your specialty, because you will have pathology that goes over both of them. So this patient had swelling above the medial canthal tendon, nasal obstruction, the globe was pushed out. Can you see how that eyeball is pushed to the side? And this patient had a lymphoma, and you can see the eyeball was pushed further out, and she was actually lined up for an operation on the lacrimal duct. She was lined up for it by one of our fellows until someone else just took a torch, shone it up the nose, and saw this mass up the nose, and she was diagnosed with lymphoma, as you see on the scan there. So operation was cancelled. Well, it wasn't. She had a biopsy instead to identify the fact that she had a high-grade B-cell lymphoma. So lymphomas are quite common. We see a lot of these now, but the treatments are getting better every single year, and it's no longer the sort of the death knell that it was. The treatments are very good, some of the multi-chemotherapy treatments for these. If, on the other hand, something happens very quickly, if the patient says that their problem happened almost instantaneously, that normally implies a rapid bleed into the orbit. So here's a young man who was absolutely fine, and he woke up. He said, I woke up and I had this really painful eye, it was really bulgy. We did a scan. Can you see the fluid levels in that scan? It's quite nice how you can see the layering, one layer above another. And we took it to theatre there and exposed this unusual vascular anomaly, which we then drained. And as we drained the blood from the orbit, you could see the eye going down. It's quite remarkable. And he was rolling, he was sick. He was really sick because if you expand the muscles around the eye, you feel sick. all right? It changes your heart rate. And so if you have someone with a bleed around the eye, the patients feel really nauseated and they're unwell, and if it really squashes the optic nerve, what happens to their vision? It drops off, and it can drop off quickly. So that procedure can relieve the pressure and give the patients back. Here's another one. The elderly lady woke up, and 2 messages. There you can see the hemorrhage, like a beached whale. We call it a beached whale in the orbit. And it's always important for all oculoplastic surgeons to ask their patients to smile after any operation. It just has a better effect on the audience, right? So here's a lady who drained, the eyelid's gone back up, and she went from almost no perception of light to seeing normal vision, almost instantaneously. So something that's sudden, what do you think about when you see something that's sudden? What happens? What is a sudden pathology? Hemorrhage, okay? Hemorrhage, and it may require very urgent treatment. So I'm going to stop at that, but you've had a lot, and I'm going to come straight to the summary slide. You've been a fantastic audience. Diagnosis of lid swellings, or instead of lid swellings, any other condition, anatomical area that you are studying is based on pattern recognition, and you are going to use subliminal algorithms. The older you get, the more subliminal, the less cortical, and the more brainstem they become. But at the moment, you're trying to put this onto your cortex, and it's quite hard work with all these exams, but the more patients you see, all these algorithms are driven deeper and deeper, so that you start to diagnose people just by what they tell you, as much as by what you find when you examine them. Only the essential investigations are required, whereas if you go to some parts of the world, you walk into the clinic, CT scan, you walk an MRI scan, but the good, astute physician will recognize the pathology from the history, okay, from the history, whether it's sudden, bilateral, slow, and so on and so forth. A biopsy is often necessary. In your lifetime, perhaps after I've retired, tumour markers are going to play a major role in how you deal with a lot of these conditions. CT is the imaging modality of choice. This is really more for the ophthalmic audience, that statement. And I'm going to put them all together. This is what you've learned. If I showed you this at the front, you'll all be asleep by now, but the fact is none of you are asleep. And that's why I didn't show it to you all at once. But that's what we've been through today. It's a heck of a lot, isn't it? But we've broken it down in ways that have made it much more easy to understand. And I bet you if I showed you these pictures again without any of the titles, most of you would get it right. So thanks very much for your attention.
Thank you very much, David. Now, do you feel able to cope with another 20 minutes expanding from the eye down into the rest of the face and back into the brain and things like that? Do you feel up to that? Okay, fine. I think there are 2 things I'd say about David's talk. Obviously, it was very dense, very complicated. You're not going to remember most of it, but you've got the handout, I think, haven't you? So that will be helpful to you in the future. But I think there are several things that he said that are nuggets, pearls of wisdom. Unilateral sore throat, unilateral earache, unilateral anything is abnormal. Bilateral is often a sign of an infection, a viral infection or something like that. Unilateral is a sign of tumour or something similar, something to worry about. Is that your... yeah, okay. The other thing is that what you saw there was an experienced clinician trying to bring his subliminal thing to the surface to aid his colleagues in what was a very complicated algorithm. I don't expect you to know that algorithm, but what I do. We've got a test on it, haven't we?
We had it, yeah.
No one's leaving. No, the point is that when I saw the algorithm for the first time, it is, even when you see it individually, it's quite complicated. But it's showing how a clinician is trying to bring complexity into a simple binary system whereby you say, okay, if it's a child, it's this. If it's an adult, it's this. If it's a teenager, it's this. If it's, so you're going down a pathway, splitting all the way until you end up at the answer. And that's actually what you're doing in your brain. And so what David has done is to try and, how on earth am I going to find this? Periorbital. So I'll go down this quickly. This is not a Mac, is it? So I can't. How do I drag it down? If you could find it for me, look after me very much. So it's the periorbital. Yeah. So I think the key thing is that think all the time of how you can make things simple, how you can make things easy for yourself. That certainly wasn't an easy talk, but what David was trying to do for his colleagues was to say, think, instead of just thinking knee-jerk, try and think it through by breaking it down into pathways. Okay, all right. So now, should we do it on the desktop? Okay, and I'll just do this. Okay, that's the arrow, is it? Okay, so that's me, that's what I'm talking about. So, here's a very straightforward thing. A person with a melanoma of the lateral aspect of the eyelids, and if you look closely, you can see that I removed the outer aspect of the eyelid, and what you can see is the conjunctiva there, and then I have to close that. So it's skin going onto the eyelid. That's him immediately after the operation. I'm not going to show you the face at rest. I'm going to show you him smiling, because you can see actually he's got some distortion of the lateral aspect of the eyelid. It's not a perfect result, but fortunately when he's smiling it's okay, so he has to smile the whole time. I'm not letting my patients look miserable. As David said, this is a case of David's that he invited me along to fiddle around with. It was a patient who... well, David, do you want to tell the story of him?
This chap was only allowed to fly on British Airways back from Spain on the basis he wore a big pair of sunglasses, because he'd been like that having had gastroenteritis, and he'd developed a septicemia and developed this horrible infection around the eyelids, and was basically in Marbella, and they wanted to get him out as fast as they can, so they said, here's some big sunglasses, you're well enough to travel, get back to Milton Keynes, which he did, and he pitched up the next day into my clinic, and my fellow, who was very understated, said, Mr. Verity is a patient down you need to see, I think he may need some skin grafts at some point. I looked at him, and I thought, this is beyond probably what an average oculoplastic surgeon can do, and that's actually how I started working with Iain Hutchison, somebody who works to you.
So what we did was we did a forehead flap, a transposition flap from the forehead down to the eyelid, and I left a horrible mess there, and David tidied that up into a... so I gave him the wherewithal, the tissue to use, and he turned my sow's ear into a silk purse eventually for the guy. And then, I think I've missed out on somebody. Yes, I have, yes. So here we have Regina, who has an AV malformation. And what happens is she can see out of that left eye. It's proptose, it's completely covered by the arteriovenous malformation, which is pulsating, and which was operated on here, and which required pretty extensive dramatic surgery, taking about 8 hours to debulk it, but leaving her eyelids and leaving the eye. Subsequent to that, because it had forced the face down, she needed facial osteotomies to bring her upper jaw up. She had virtually no bone of the maxilla because of the long period of time that had been pulsating away. Should we have these lights down a bit more? I don't think people can see very well. How do I do that? Press that. Press that.
It's fine.
That's fine, it's okay. All right. Here's another case, a woman with a sarcoma operated on by 2 great surgeons in America. The flaps that they put in failed, so even the best of surgeons fail, and she rings up from New York and says, can I come over and see you? I've got this defect in my face, and actually it requires a simple reconstruction. It doesn't require bone. She's got an obturator in there, and that deals with the maxilla and the sinus. So she speaks well, she eats well, that's fine. But all we need to do is put some soft tissue in there, so we used a radial forearm microvascular free flap. I had to go over to New York to do it because her insurance didn't cover her here, and the surgeon over there got me operating rights in his hospital and arranged for me to, because he was getting paid for it, and got me, I didn't get any money for it, but I got a nice stay in Trump Towers at the bottom of Central Park, with a great big room overlooking Central Park for 4 or 5 days, because of course I had to stay afterwards to make sure she recovered from the operation. We talked about rhabdomyosarcoma. This is a young man with a rhabdomyosarcoma, and he's a triumph for the oncologists. And they go around saying, look at the patient I've treated, they've cured of their rhabdomyosarcoma. He's now 18, he's going off to university. But actually, it's about looking at the patient as a whole. This patient is not a very happy person. They're alive, but he's 18, he's going to university, he's leaving home, and he looks like he's got a lantern jaw, but he doesn't. He's got
maxillary hypoplasia because the radiation that he had as a child has caused the left side of his face to fail to grow completely, which is why his nose is across to the left and why his eye is sunken in. But also his right side of the face has been affected, so the right side hasn't grown as much either. And what the problem is with that is that you can't do anything about the eye. You can't bring the eye forward. But maybe this is something we should look at, David, because we've got a lot of kids with rhabdomyosarcoma who are alive, and we can't do an osteotomy on them because the soft tissues won't allow us to move the bone forward. So what we can do is we can lift the face off, and we can put in fat to make the face look as though it's full, but then make the eye look even worse unless we can bring the eye forward. So, or put a shell prosthesis over the eye, but, a discussion to be had. Here's the eyelid tumour that you saw, and some of these you'll see paintings. These are the paintings from the Saving Faces Art Exhibition, which you're free to use in talks, as long as you give credit to the artist and to me, because I paid for it. It cost me almost £100,000, I think, by the time I paid the artist for the time he spent with us. This little girl is from Glasgow. She has, you could see it's interfering with her vision, irrespective of anything else. Of course, it's going to shrink with time. We think about 50% of them will shrink completely by the time they're 18, but that means she's got to stay like this until she's 18 years old. And the other thing is that it ends up as a fibro-fatty mess, and so it will need some surgery at that stage. So it's a reasonable thing to consider to take it all out, and she's got a midline scar, and you can see that it's not particularly visible, and she's happy with that. This is a Henry Ekpe, who wrote to me. He was a nurse in Nigeria. He was 25 years old or something, 26 years old, and he said, I've had an operation on my maxilla for a benign tumour, and it's just left me with disfigurement, and I'd like to come over and have treatment. And so he'd never been out of Nigeria. He was fairly religious, Christian, and he found a place in Hackney, a convent where he could stay, and he raised sufficient funds to pay the hospital fees in 1990, so 1 year after I was appointed as a consultant. And he had my longest operation because I operated with my neurosurgeons, and my neurosurgeon was a young neurosurgeon who'd only just started, and we took 23 hours to take out what was in fact an osteosarcoma. This is him after he's had chemotherapy. So he had chemotherapy first, then surgery, then radiotherapy. We took out his right eye, which is proptosed, as you can see. We took out his nose, the nasal skin, the facial skin. We took out the two recurrent tumours in his temple, and we took away his orbital floor, his orbital roof, the maxilla, so the orbital floor as well. So we took out the face, and this is him a little while afterwards with an obturator in, with skin from his back, with a rib to reconstruct his arch, but with his eyelids preserved, and he could still move his eyelids, so because the tumour went up behind the eye. And this is him many years later. He had a further bout of that tumour about 6 years later on the left-hand side of his face, which required resection of the left maxilla and orbital floor. But obviously we want to preserve the left eye and reconstruction with a microvascular free flap for his maxilla. And then he developed a tumour in his intracranially. Fortunately, he was on the dura because I arranged to operate on it with my neurosurgeon, and my neurosurgeon didn't turn up. So in the end, I, as an oral and maxillofacial surgeon, had to do a neurosurgical operation. But we'd operated several times together, so And anyway, just like I was saying about David, he was ready to do the hepatectomy on the patient the other week. Anyway, he subsequently got married. He had Jeremiah. He became a charge nurse in a West London psychiatric unit, and had a happy and fulfilled life for about 16 years, but ultimately died of metastases at the base of the spine, and he died about 2 weeks after he developed low back pain. He fell downstairs 2 weeks later and died. This is Mazida, who's a girl from just beyond Tower Hamlets, who I was called to see at Queen Elizabeth Children's Hospital when that still existed, who had a malignant yolk sac tumour. This is her after chemotherapy, so this is residual tumour still. She can't see out of that right eye. You can see it's proptosed, and then she has surgery, and she's painted by the artist in a way that I said he shouldn't paint patients. So originally I said, I just want you to paint the patient's face, nothing about the body, none of the the stuff that you normally put in, like the bookcases behind them and stuff like that. I want you to focus on the face. Anyway, this was the first one where he did a full-size painting. It's a 6 foot tall painting, and he paints her down in the corner of the painting to you can't see that because I've just taken that section out, to highlight her smallness. You can see that her feet don't touch the ground. Her mother wears a full burqa, but she sent her along to be painted with a little pink ribbon in her hair and the green velvet dress. And every art gallery that we went to in the UK, the parents came with Mazida to look at the painting that was exhibited and the way the audience reacted to it. This is Henry de Lotbiniere, a barrister, educated at Eton and Cambridge, I think, and a very handsome man. When he was young, he wanted to apply to be the James Bond person. He provided me in that. And this is his second operation for a squamous cell carcinoma of the, adenoid cystic carcinoma of the maxillary sinus. And what happened in this operation was he was 2 years post his first operation, and he came to me. He'd been operated on by my predecessor with his ENT colleague, and they'd done a maxillectomy where they hadn't taken out the whole tumour successfully. He'd had radiotherapy afterwards, he got a recurrence, he was up at the skull base at the back in the infratemporal fossa, so I peeled off his facial bones, osteotomized his zygoma and put it back again afterwards in what's called a Crockett manoeuvre to get access to the infratemporal fossa, and this is him looking pretty good. But this is him much later on, after about 12 of the 16 or 15 operations, I can never remember which, that I did on him. In the second operation I had to remove the eye, and he didn't look quite as bad as he does in this painting, but essentially the adenoid cystic carcinoma just came back again and again and again and ate through the reconstructions that we did. He lost his lower jaw, and the last couple of operations were intracranial operations around the optic nerve to decompress the optic nerve so that he could see in the right eye. And he was still working as a medico-legal barrister until about 5 months before he died, and he died of his lung mets from adenoid cystic carcinoma. He went away for the weekend to Devon, to his normal holiday place, and died there at the weekend of pneumonia because of his lung mets, about 16 or 17 years after the original thing. This is quite an interesting picture to show because one of the audience says that he doesn't like to come to lectures because he goes off to sleep in them. And you look at the husband behind this woman, you think he's asleep. He's not actually asleep, he's thinking. And he's very supportive to this woman who has a malignant sarcoma. She's tried one chemotherapy, and the chemotherapy failed to control the disease, and also gave her very severe side effects, so she couldn't take the chemotherapy. So she came in, and you could see she's incurable because the tumour is wrapped around both internal carotid arteries in the brain. So it's impossible to remove it surgically without killing the patient. So we had to go for something which was a palliative treatment, which would allow her to have less pain and a reasonable quality of life for the 18 months or so that she had to live. So this is us preserving facial skin. We peeled back facial skin, had to take away some skin, preserving her upper jaw, showing the tumour out from behind the eye, and leaving the eye in place, and so that she can see out of it, and so that she has an eye, even if she couldn't see out of it, so that she has an eye that is cosmetically better than not having an eye, I think. Here is a very famous actress who had lots of Botox injections, and one day she had a Botox injection in her cheek, and she screamed with pain, and the surgeon who was doing the Botox injections, the plastic surgeon, eventually biopsied the area, didn't find anything, biopsied again, didn't find anything, but then she ended up in the hands of a professor of plastic surgery at Mount Vernon who found melanoma there and did a resection you can see around the right eye, but subsequent to this, the melanoma recurred in multiple places around the eye, so she had an orbital exenteration writ large with facial skin and maxilla removed, and so what you're looking at on the left-hand side is the lateral orbital wall, which was left in place, and the whole of the orbit removed and a lot of facial skin. And what you're looking at here looks like a huge mess, but is in fact has scapular bone used to replace the kind of cheekbone area to give contour, and skin to fill in the eye. And admittedly, it doesn't look particularly good, but it's a bland reconstruction, and what it enables the patient to do is to wear an eye patch 6 weeks later when she's performing in Chichester, the Chichester Festival Theatre in the Seagull, as the star of the Seagull, with her daughter playing another part. And it blended in well with the part because she's playing an aging actress who's in love with a young man, a handsome young man, and who's losing the young man to a young woman, and is very worked up about that. So the eye patch came in very handy, but it shows that you could have somebody with malignant disease who can be treated and be back to work in the public eye very soon. This is the young man who had the hepatectomy recently that David and I operate on together. We started looking at the eye and the melanoma that he had around the eye, and this is, you can see the orbital contents there with black all over the place. That's melanoma. And then the eye is out, and what we're looking at is at the back of the eye socket, so over to where my thumb is, or David's thumb, I don't know which thumb it is. That's the nose. This is would be the left temple, and you can see we've removed a lot of bone around the eye socket, and we're looking at the back of the eye, the superiorbital fissure, and we can see black going intracranially. So we drilled away a lot of the bone there, and then we started going down into the sinus, and we found melanoma right down in the maxillary alveolus, above the teeth, at the bottom of the maxillary sinus. We hadn't planned to take that away, so what we did was we did an operation where we closed that area, and then we went back in later on and removed the bottom too. And this is us before we put in the scapular flap. So having removed the maxilla from below, we put in the scapular flap and get Andrew Darwood to come along. This is him with his upper eyelid preserved and with his facial bones replaced by scapular bone and facial skin replaced by skin from his thigh. And that is Andrew Darwood making a bridge for him. And what you can see there is the skin from his back, scapular skin, and the implants have gone into the scapular bone that you saw on the 3D model. Here's a young woman who had an orbital exenteration, but her eyelids were preserved, and she came down to see me, and we put in a radial forearm flap. She can close her eye around that. And she's tried prostheses and mucosal grafts, but they've been irritating and not really worked well. Here's an alternative to this, which is Andrew Darwood at his best, somebody who's lost half their face pretty much. He makes all sorts of contraptions to support a prosthesis so that the guy can go out and live in society. Not perfect, but better than the other thing. So we've seen innovations which have enabled us to do this: microvascular surgery, anaesthesia, so we can operate for 23 hours and the patient can leave hospital 2 weeks later, engineering, dentistry, psychology, but we need clinical basic science research. So here's the advertising thing. Every one of my talks, stop laughing, Indra. Every one of my talks has the National Facial, Oral and Oculoplastic Research Centre in it. It's the world's first dedicated centre, and it is unique because it's the specialty associations combining with the Facial Surgery Research Foundation. So they put in the intellectual input, the Facial Surgery Research Foundation fund it and provide the research infrastructure to enable research to go ahead on hundreds of thousands of patients. We anticipate 4 million patients in 10 years every year on our databases. The total research costs are pretty cheap, £1 million a year, with total admin costs of only 30,000. But ultimately we'll have 4 million patients, so that means, what does that mean? That means they cost 25p each to enter their data and collect their data. Not bad. And that's our legacy for the future. Thank you very much indeed. And thank you, David, for giving a terrific talk. If you want to ask any questions, do you want to pack away your things so that we can get out of here and we're not locked in, because we were nearly locked in last week. If you want to ask any questions for 10 minutes to David and myself, I'm very happy. But the most important thing is that you sign the sheets saying what a wonderful program this is and how you want more lectures next term. Any questions? David, do you want to come up and is there any questions?
May I ask you please, actually, the sebaceous carcinoma. I mean, I like to have these lectures. I'm still learning even though I sort of get one bit now in my career. But I wasn't aware that sebaceous glands would become malignant. So if that is the case, why should that happen in your field?
Well, good question. Because of the oils that are produced around the bases of the eyelash follicles, so it's really the sebum that's produced around the adnexal glands in the eyelids, so absolutely full of glands of cysts, mole, and sebaceous glands as well. So the sebaceous glands in the upper lid, and there are about 40 of these long acini, produce the oils that float on the front of the tears, because without the oils our tears would evaporate very quickly. So the more oil we have on the front of the tear film, the more comfortable our eyes are, but when those glands become cancerous, that's a sebaceous gland carcinoma.
If I could just have license to ask one brief question. The patient who presented being treated with drops and so on, medically, clearly it was a malignancy. Had that been continued with treatment, and she presented to the dentist, for example, what would be a manifestation of metastasis from that lesion?
Well, ultimately, the metastatic rate is reported to be about 40% of these patients, and they can present with lymph node metastases to the liver and elsewhere. She hasn't, and that's probably driven genetically as much as anything else. Some patients you treat early metastasize, and some you don't, and they don't metastasize. But she would have got increasingly lash loss, red lids, sort of scarred, slightly gnarled lid margins, increasingly red, uncomfortable eye, and eventually the penny would have dropped. She wasn't doing the rounds for years, but she's certainly been around for a year or so, some of which had been in an eye clinic. And there's no criticism of eye clinicians at least, but it's just to say that when something's unilateral, that the penny should always drop. Could this be something more serious? And as I say, I've had about 5. We've just we're presenting this at our national congress next week. We're just about to publish a paper on it, and I've seen about 5 in about as many years, so it can't be that uncommon. But it's the unilaterality of it, I think, that's the most worrying feature. As Iain said, unilateral sore throat, ear, eye, anything you like, is more worrisome than bilateral. Now, a lot of eye doctors will look at that and say, well, does that mean every one of my patients with a bit of blepharitis on one side has cancer? Of course it doesn't. It just means, please think about it.
Any other questions? Well, I think you're brilliant staying here for this length of time on the only summer evening we're going to have in the whole of this year. But cycle day? Yeah. Yes, okay. Well, wait a second. You mean in September? You're talking about our cycle day. Do you remember the cycle day? I've got to get my diary. 8th of September. Who has ridden a bicycle in their life? Who hasn't ridden a bicycle in their life? Okay, so you can all ride bicycles. Okay, what we do is we have a great day. September's a wonderful month. It's warm, and we have a cycle day. It's a private area, so little children can cycle, elderly adults can cycle like me. We've had grannies and grandmothers cycling. It's a track which has which was used for training for the Olympics. The cyclists used it beforehand for training. It's got some hills on it, but you can go on a flat piece, which is what I do. It's got a BMX track, which is for people who like doing BMX rough tracks. And the track is about 2 miles, so it's not too far. We have bouncy castles for children, not for adults. We have food and drink there, music there. It's a great day out, and it raises funds for Saving Faces. So I'd like you all to sign up.
Registration is open online on Saving Faces.
Yeah. And so try and raise money for it yourself. And if you're not going to cycle, try and get somebody else to cycle on your behalf and raise funds for them. Okay? The more people that cycle, the better, because it's more fun. And also, you know, if we've got, I'm very fond of the Jesus principle, which is, you know, you start with one man, and then you have the disciples. Was it disciples first? Yeah.
11 good ones.
11 disciples first. And then the disciples go out and get apostles. So, you know, it's pyramid selling. It's pyramid selling of religion or of this. So what you do is, I had one patient who was unemployed, and he went round all the pubs, and I said, will you sponsor me, when he came to the clinic? And he said, yes, I'll sponsor you. I said, well, let me change that. Don't sponsor me. I want you to go around to everybody you know and try and get money off them. And if you just get £1 off a lot of people, they'll be fine. He came back with a Sainsbury's bag of £740 in coins, because he'd gone into all the pubs and he'd said to people, give me £1. Pound, what's that? You know. So just get lots of your friends to sponsor you, even if it's only for £1, and you'll be surprised how much you can raise. So have a lovely summer. I'm going to miss you all, but you're not going to miss me. We've got things to hand out to people, certificates to hand out to people. Anything else you want to say, Coral?
I just want to say thank you on behalf of all the students to you, Iain and Hutchison, for doing such an amazing lecture series and organising it for everyone.
Well, honestly, it's my pleasure. I'm thrilled that you've come along, and I hope you've enjoyed, if not all of them, some of them. And it's about, we haven't had a patient here today. I did actually ring David to ask whether he'd get up from his hospital bed in Addenbrooks after he'd had his hepatectomy to come down here, the guy who you saw, to talk to you about the experience. But we only had a week or so, and David, I'm sure, would have found a patient, but he was operating today, and the patient was still anaesthetised when he left. Otherwise, he'd have brought him along. So, you know, I think the key has been the patients, really, would you say? The patients? And sometimes the other disciplines feeding off each other. So, anyway, it's been great for me too. Lovely to see you all here.
And will it be again next year?
Yes.
They got a date, or will that be set in the future?
Well, when we say next year, yes, absolutely. What we're going to decide is, do we continue to have it here? Do we change the timing of it? Do we change the day of it? That kind of thing. So if any of you want to contact Izzy and Corwin and say, look, we thought Tuesday was not a good night to do it, can you do it on another night? Could you do it a bit earlier or a bit later? You know, that kind of thing. Because some people are coming from other places. And maybe next year we might look at linking it with other medical schools so that we beam it to other places too, so they can watch it.
Yeah. So you know where to come if you're interested in being part of the society at Barts. Me or Cora. And then you can take it over next year and help out.
I mean, tell me what you're doing next year. It's your last year, isn't it?
Yeah, we'll still be very much part of it, hopefully.
But you've got other priorities. Haven't you got to do an elective next year?
Yes, at the end. Oh, actually, by this time I'll be away, actually, on elective.
Yeah, okay.
Yeah.
So that's one thing. And then you're studying for exams. Corwin, what's your state of play next year? No, but what have you got 5 major exams next year? Are you going away next year? Off and on. But we need help, you know, they need help and stuff. I just get the speakers together and they organise the lecture theatres and let people know and email people and Facebook and all that kind of stuff.
Yeah.
So they do all the hard work. If you want to help, they'd be very keen to do it. Otherwise, it's going to possibly fall flat unless we have a little bit of input from some of the students.
We have 300 members on the Facebook group now for Barts.
Okay.
So I don't know how many of you are part of that, but if you want to join, it's called BL Saving Faces. Probably got lots of friends.
And if 300 people cycle, and if each of them raise £100, that's
Yeah.
£30,000.
Exactly.
It's free. You don't have to pay to very often when you do these things, and you can set yourself targets. And the only injury I've had is a wasp sting, because I was cycling along with my, it was so hot one year that I was cycling with my kind of shirt flapping around, and a wasp go on underneath, and before I knew it, I'd been stung. So it's a very safe thing to do. You're not doing it on a public road. You don't have to worry about traffic. When you get tired, you can just get off. I've done an A to B cycle ride, and I got about 50 miles into it, and I thought, this is stupid, I'm going to die. I'm meant to be a surgeon. And I got off my bike and I started walking. My Achilles tendons were killing me, my heart was killing me, I was in a miserable state. Unfortunately, a car came and rescued me after I walked for about 15-20 minutes. But so at that point I decided no more A to B cycling, because once you start, it's just as far to go back as it is to go forward. So, what you want to do is just go round and round in little circles. Okay. Thank you very much indeed. Have a lovely summer. Don't forget to fill out your forms.